I cannot believe the time is now. Like, it's happening. It already happened. We have the approval. I think just a few weeks ago, we were talking about what will happen to DB11 and what will happen to DB05, but now it's approved. We have T-DXd approved for early stage HER2 positive disease as well. And we got the approval for both DB11, which is a neoadjuvant strategy, and DB05, which is for the residual disease setting, the way we had TDM1 for the Catherine trial. Maybe, Sarah, you could tell us first about, what do you think about the label?
Well, it was exciting to see the approvals, as you noted, and I will say I was also a bit surprised by the label indications because they're a lot broader, actually, than the clinical trials. So, for example, the approval for T-DXd for 4 cycles followed by THP for 12 weeks in the preoperative setting was based on DESTINY-Breast11, and its indication is in stage 2-3 HER2 positive disease. Whereas the trial itself, the pre-op DB11 study, was specifically for patients who either had node-positive disease up front or had a T3 or greater tumor. So this is a little bit broader than the trial itself was. And likewise, for the residual disease setting, that indication was based on DESTINY-Breast05. That trial was really designed for patients who either had inoperable tumors at baseline, went on to get pre-op therapy, then had residual disease, or they had residual node positive disease at the time of surgery. So it was a very high-risk patient population, but actually the indication is for any residual disease. So it isn't quite so specific as the DB05 study was.
And do you think that's a good thing? You're happy with this pleasant surprise of this broad label?
Yeah.
How do we think about it?
Yeah, I mean, it was a surprise, right? I would call it a pleasant surprise. I think it does allow clinicians to practice as clinicians and use some of our clinical judgment. I will say, I think the right populations were tested in the early stage T-DXd trials. I mean, there's always a risk benefit and ever more so in early stage curable patients. So I do think they chose the right populations. And although the label is pretty broad for both neo and adjuvant, I think in my approach, I will probably, at least initially, start by really adopting T-DXd as was done in the studies, in the higher risk population. I could see that evolve over time, as we get more comfortable using and monitoring, particularly, that there may be additional populations that would be appropriate.
Yeah, no, thank you both. I think maybe because we have 2 settings that we're thinking about adoption as you were talking. Maybe let's take DB11 as a first example, right? So what were you doing in the neoadjuvant setting? Maybe walk us through that, say 3 months ago. What are you doing today, and how do you anticipate adopting this approval and doing something in the neoadjuvant setting for your patient when it comes to neoadjuvant? So maybe if you want to comment on that, that would be great.
Yeah, so I think for my higher risk preoperative patients, I was mostly using 6 cycles of TCHP, so docetaxel, carboplatin, trastuzumab, pertuzumab, so 18 weeks of pre-op therapy. For the kind of intermediate pre-op patients, so those patients maybe who were T2N0 or the really large T1C and 0 patients where you really want to give them pre-op, I was actually just giving 12 weeks of THP therapy. So I was those people who were on edge for pre-op were the people I was giving 12 weeks of THP. So, I think that has been my standard to date. I think thinking about now having the DB11 regimen available, I think I would think about it for those higher risk patients for whom I was triggering the TCHP treatment recommendation. And so I think those node positive patients, for example, the large tumors, those are patients where I would think about T-DXd followed by THP in that setting.